Mission and margin is the business of healthcare.
And we want pharma to be in the game with us. No outcome, no income. Meaning, if we have a readmission, we got to eat it. If we have a hospital-acquired infection, we got to eat it. If we chose the wrong antibiotic, we got to eat it. If we didn't follow through on the chemotherapy and we didn't describe the side effects, and patient can't go home for 2 days, and on and on. So to be at economic risk with us, that's something I would love to see pharma do more of that.
That was Dr. David Nash, Dean of the Jefferson College of Population Health. Health systems manage the selection of pharmaceuticals and other supplies through a health systems pharmaceutical and therapeutics, or P&T committee. This committee facilitates consensus amongst medical staff, administration, finance, supply chain, and departments such as pharmacy. In this interview, we challenge the status quo of the contemporary supplier health system relationship, which is a complex web of supply chain business relationships, price negotiations, and market share trade-offs. Dr. David Nash is the founding dean of the Jefferson College of Population Health, the nation's first academic institution focused on that specialty. Dr. Nash is also a practicing primary care physician, an active member of the Jefferson Health P&T Committee, and a much sought-after speaker on population health and healthcare policy. I began by asking Dr. Nash to define population health.
So, population health, what exactly is that?
Yeah.
Pretty great, isn't it? So, in 2003, Dr. David Kindig, then at the University of Wisconsin in Madison, writing in the American Journal of Public Health, said, hey, public health is great. You know, AIDS prevention, obesity reduction, driving 55 miles an hour, eat your fruits and vegetables, get vaccinated, get a flu shot. Who could argue with that? It's like the Eagles winning the Super Bowl, right? Outstanding. But in his 2003 paper, he also said, we're not thinking about the broader issues, the social determinants of health, what role poverty and education play in achieving good health, what does all this cost, and what is the quality and safety of what we're delivering. So we embraced that term in 2008, almost 10 years ago now, when we started the nation's first college of population health. And I think in 2010, 2 years into, after the creation of our college, of course, Obamacare was a rocket ship to promote the concept of population health.
What percentage of the U.S. healthcare dollars spend do you think is exposed to risk today?
Well, I think it's probably about 10-15%.
Yeah.
It's modest.
Yeah.
But so that brings up the broader issue is, where do we think the world is going?
Yeah.
I think the world is inexorably headed to the world from volume to value. I don't see how we could get around it. Is it going as fast as David Nash would like it? No. I think bundled payment is the way to go. Let's put it this way. The research evidence is solid. You want to change clinician behavior, you got to change the economic incentives. And the way to do that is no longer just the gatekeeper model of a primary care doctor like me making every decision. That's not it. What we need is to involve the specialists, everybody's in on the act, and the delivery system itself. Here's your pot of money. Now you guys and gals figure out what's the best attack. So looking at it another way, it's $10,000 per person in 2017 of healthcare spending, including children. Are we really getting 10 grand of value for every person in our family? So I have 3 grown children plus the boss, that's 5 of us. So 50 grand. Did we get $50,000 worth of value out of the healthcare system last year? Hardly.
It's a big problem. We understand from data that was published a couple of days ago, perhaps price.
Yeah.
What's your reaction to that?
You're on top of the details. That's wonderful. Yeah. So people ask me all the time, okay, big mouth, why is healthcare so expensive? Yeah. That's a really interesting question. It's got 3 easy answers, right? Generally speaking. 1, we do more stuff at a greater intensity across the lifespan than any other nation on earth, right? So my 95-year-old father-in-law, God bless him, still alive, has all his marbles. He just had some laser prostate surgery, And nobody thought a second about it. I've got an uncle in Florida, 92 years old. He's going to have a TAVR in a group that has done 300 TAVRs in men over 90.
Wow.
Wow. So number one, greater intensity of service than anybody else in the world. That's one. Two, more expensive. So on a price comparison basis, we charge a way higher price. And number three, salary. So salaries of healthcare workers in the US are way out of whack compared to the rest of the Western developed world. So Zeke Emanuel's paper in JAMA, lots of other great people looking at this. So intensity of service, price, salary. Those are the major components. And I think you'd have to say part of number one is diffusion of new technology. And doctors, we love our new toys, and we don't give up the old toys. You can't take my old toy away. I want to use that and the new toy, and yet we don't really focus on the outcome and what we get for the buck that we spent. But those are the three reasons why it's so expensive.
Rapid change.
Yeah.
We talk about the rapid change.
So I've been on the P&T committee at Jefferson since 1990. It's a long time. And I chair one of the subcommittees which is involved with medication quality and safety related issues. So adverse drug events, medical error, and so on. And ages ago, reps called on us. Of course, I haven't spoken directly to a rep in my role as a primary care doctor in probably almost 10 years now, right? And if you look at Jefferson Health, it's a great reflection on the marketplace, meaning when I got to Jefferson, we were one hospital, and now we're 14 hospitals. We're struggling to create an enterprise P&T committee. We're struggling to get better outcome measures. We're spending tens of millions of dollars in acquisition cost across the whole spectrum of products. So we need people from industry who aren't just going to give us stuff we could get online or read in a journal. We want to understand, well, do you want to work on a project together? Do you want to gather some data? You want to write a paper? You want to look at some research-related activities together? That's what I'm interested in.
There's a downward trend in the number of salespeople employed in pharma. So most pharma organizations are shrinking their workforce. They're also changing the makeup of that workforce. And that workforce is shrinking. You got a new set of competencies that they probably need.
Right.
Where would you focus their attention?
What I'm suggesting is that I can get the clinical information from any number of sources. I don't need a face-to-face download. What I need is, look, Dr. Nash, I'm willing to help you with a project to test whether this was a good decision to put product ABC on the formulary as opposed to product XYZ. And I'm willing to invest in helping you gather the data. And I'm willing eventually to potentially go at risk with you. You bring me somebody like that, I'm ready to embrace them and do business with them. And I think the other, smoking gun here is the PBM role, the discounting, the middleman. The average American has no idea that 3 or 4 companies have every prescription every doctor's ever written on file. They know exactly zip code by zip code in this town, what's working in this zip code versus what's working in this zip code, and in every other town. So, I'd like to understand that data. If you brought me my own information about how we're writing scripts, and we fed that information back to the script writers to achieve a change in behavior, that's a great partnership opportunity. Lots of companies don't want to touch that. Well, we need good comparative data. We need cost effectiveness, cost benefit analysis. The days of quality adjusted life years swaying a P&T committee to make a buy or no buy decision are long gone. We want head-to-head comparison data, not against placebo. And here's the biggest nut, we want them to go at risk with us. Why should I put your product on my formulary, you bearing no economic risk? Why do I need that 10th beta blocker, that 11th ACE inhibitor? We're not going to do it. So we want to know, and you use the word, the system and so on. Well, okay, pharma, bring it on. We'd like you to go at risk with us. And we have a 4-word way of explaining all of this, which is really pithy and easy. No outcome, no income. And we want pharma to be in the game with us. No outcome, no income. Meaning, if we have a readmission, we got to eat it. If we have a hospital-acquired infection, we got to eat it. If we chose the wrong antibiotic, we got to eat it. If we didn't follow through on the chemotherapy and we didn't describe the side effects, and patient can't go home for 2 days, and on and on. So to be at economic risk with us, that's something I would love to see pharma do more of that. I understand the issues, it's complicated. There are some leading companies, certainly Aetna and Merck have gotten a lot of press, but we did a deep dive on the at-risk contracts just a few months ago for a national conference here in Philadelphia. It was very hard to find real data. There's very little published information on providers and pharma going at risk together. So the system we already established, it's about 10 cents of every dollar is drug-related, pharma-related. So we want you to be in the tent with us, and we want you to feel our pain, and appropriately, we want you to share in the gain. Look, we're also facing lots of internal behavioral issues. So in today's crazy upside-down, inside-out reimbursement model, one guy's waste is another guy's income stream, right? Let's give a concrete example. So right at this moment, all kinds of unnecessary tests are going on, even in my health system, all right? Across our 14 great hospitals. And we know that tomorrow, a bunch of 40-year-olds are going to get a inguinal hernia repair. And they're probably getting pre-op chest x-rays and pre-op EKGs and all kinds of blood work for which there's no scientific evidence whatsoever that they need it. So that's the waste, but it's also the income stream for the lab, for radiology, for cardiology to read the EKGs. So we've got to break that crazy cycle. If I give you a bundled payment, you're going to be more parsimonious about which test and which person and what's the evidence. You're going to go back and look at the evidence before you make a decision. That's where we got to go. Hey, I know it's a hard job. We've been at it for 3 decades, but now we've got this platform is engulfed in flames. It's not just smoking. Yeah. We got to get this done.
Why is it that pharma has such an anxiety about taking on risk? What's the exposure there we sought very hard to get pharma to come talk about a risk-bearing strategy and supply chain, and there was a reticence to have that conversation. What were we picking up on?
Well, that's a tough issue, certainly explosive issue. As we already mentioned, some of the big organizations that come to mind, Aetna, Merck, and others, have had some modest success, Lilly, some modest success. I think a couple of things are standing in their way. So first of all, lots of lawyers, so that's always a challenge, I think there isn't good head-to-head research data because they've not been compelled to produce it. They've been compelled to produce product to placebo, not product A to product B. So we don't really have the research evidence. That's part of the problem. Then I think there's fear of the unknown. And then I think a final really important reason is what I'll call unexplained clinical variation in doctor, nurse, pharmacist decision-making. We know that where you train and where you work is a huge driver of how you practice. So something might work for Pharma A in Philadelphia is going to bomb in Nashville with the same product. So they're reluctant to create a national strategy when there's so much inherent variation. I get all that. So we've got to reduce variation, reduce waste, look at the practice guidelines, practice based on the best available evidence. This is a lifetime's worth of work. So summarize, I think pharma has some pretty good reasons why they don't want to go at risk. It's highly variable in the marketplace in the real world. Here's another challenge with the evidence, right? So if you believe all the lifetime's worth of work of people like David Eddy and Paul Batalden and an army of super smart folk, 18% of what we do at the bedside, plus or minus 2%, has got grade A evidence, right? Randomized controlled trial evidence. So let's translate. 1 out of 5 decisions, we got it nailed. 1 out of 5. So 4 out of 5, that's the art of medicine, right? Now, I'm never going to disparage the art of medicine. A bolt of lightning from Maimonides is going to come down and get me. But let's be real. That 4 out of 5, that's expensive, highly variable. Oh, and by the way, dangerous, right? So we got to find a way to improve the evidentiary basis. You know, a long time ago, I sat in a room with David Eddy, super famous, and he took Schwartz's textbook of surgery and Harrison's textbook of internal medicine, went chapter by chapter with this audience, showing that even the references were largely based on expert opinion. That most of what is in the guiding to big deal textbooks in their 20th edition is largely still grade D evidence, expert opinion. Let's not ever forget that. So when we have the evidentiary basis, well, that's swell. You want to see 2 doctors go at it. Let's get into, you know, node negative breast cancer, PSA that's gone in a white guy from 2 to 3. I mean, we could have a fist fight. Sure. So the evidence is wonderful when we can find it. I think that goes back to your previous question about pharma's reluctance to get into the risk bearing because they know that the quality of the evidence, not so great. Are you willing to hang out in a risk environment with us when 18% of the time we've got it pinned down? I get that. I feel their reticence, and I think it's in part justified.
Who's the stakeholder in the pharmacy supply chain who has the greatest economic incentive to go at risk?
Wow.
Who's going to jump out? Because at the end of the day, it's got to have shareholder value, has to be created.
I think it was a great question. So my answer to that would be the folks who are creating the most expensive products for a limited population. They have more of a controlled environment, right?
Yep.
They got more money in the game with a limited number of persons for whom there may really be a great potential positive outcome. Look, you're in a town where we've got gene therapy, the first such company of its kind, right? $450,000 per eye for a certain inherited blindness, right? So if you're going to spend that kind of dough, it better work. So are they willing to go at risk? And I would say the answer there is yes. Yes, they are. So is every mom and pop a generic beta blocker company going to go at risk with me? No, and I wouldn't expect them to. Right. So I think we could have a hierarchy of companies, most expensive product, limited number of potential patients, real dichotomous outcome, work that didn't. I think they have an opportunity to demonstrate some really fantastic sharing of information and risk sharing as well. Now it's 3-4 years from now, and we're in a much more broader bundled payment environment, and I've got heart failure bundled payment and coronary disease bundled payment, and now you're talking, you know, hundreds of thousands of patients, right? I'd like to see pharma have some more skin in the game with us in our care of those patients, reducing readmission, care coordination, all of that. I hope I live to see it.
There was a very interesting chart that you showed at American College of Healthcare Executives last week.
Yes.
It was a chart where you showed the portion of total social spend towards healthcare versus all other social spend. Can you talk about that concept for a moment?
We know, and certainly all of the scholars in population health, including a handful of our faculty, have made great contributions that it's all about poverty, crime, lack of education. These are the principal drivers of ill health in our country. And of course, lack of access. If you put together lack of access, so no universal access, and poverty, and disparity in income as a part of poverty, this is a toxic brew that leads to poor health. Let's look at Philadelphia, right? So we've got a 20-year disparity in lifespan against 2 zip codes that are 5 miles apart. 20 years, 88, you're going to live to 88 if you grow up in Society Hill, not too far from where we're sitting right now. Get in a taxi with me, go up Broad Street, 5 miles max, 68, 20-year difference. So look, poverty is the key driver. So the things that battle poverty, the social services, Meals on Wheels, maternity and paternity leave, job training, all of that soft stuff that the rest of the Western developed world spends a lot more on than we do is predictive of better health. It's not about the hospital. It's all about social service as a predictor of health. I'm mortified to tell you that Philadelphia County, where we are sitting right now, is number 67, meaning the least healthy county in our great Commonwealth, despite the fact that we got 5 academic medical centers right here. But social spending is where it's at. Healthcare spending, that's 20% of the story. Social spending, the other 80%.
Tell me more about that social spend. Is it really all about the social spend?
Programs like Meals on Wheels, appropriate work-life balance, all of that. The rest of the Western world is way ahead of where we are. Certainly, that's a big part of the jam that we're in. If you look big picture, National Academy of Medicine, right? 18% of the GDP, what's the return on that investment? Well, we're number 17 in the world. In any self-reported measure, all the research measures related to health and wellness. So we're not getting a return on our investment. So certainly social spending is a big chunk of that challenge. But I think there's a darker, much more difficult part of the challenge, which is internal to our business, and that's reducing waste. So Don Berwick, of course, creating the Triple Aim now 10 years ago, I think if Don were sitting here, I bet he would say you can't resolve the cost crisis by focusing on the cost. You got to resolve the cost crisis by reducing waste, practicing based on the best available evidence, and reducing medical error as a part of reducing waste. So if we use the right evidence, if we reduce unexplained variation, if we practice systems-based care, reduce waste, reduce error, what's the goal? Well, then we can transfer some of that $1 trillion of waste back into the system. Wouldn't that be wonderful? Imagine if we could just achieve universal coverage. That would be a tremendous accomplishment. We were on our way with the Affordable Care Act. Almost 20 million people have insurance that they didn't have in 2008. But we are actually seeing that erode. From 2017 to 2018, fewer Americans had access to health insurance. We're making progress, and now we're taking a about face. So, social spending is a big part of it. There's plenty of blame to go around. That's the punchline. For better or for worse, our generation has made a mess of it. And I have faith in these new, young, incredible, well-trained, super socially aware, a lot of women doctors. So I'm excited about the future. Despite all the challenges that we face, you got to be able to put your head on the pillow at night and be optimistic that we're going to figure this out, because we got to. So much is at stake. Other than national security, I can't think of a more important issue for our great country than making sure we got access of every citizen to healthcare when they need it, and when they do get it, it's safe and it's cost effective and it's of high value. I'm going to be thinking about this, until life is over. Super important. I hope we get there.
Watch, listen, or read Business of Healthcare interviews at bohseries.com.